Let's talk about the eye. One of the great things about the eye exam is that the anatomy is right there in front of you. You don't need a CT scan or an endoscope to get started. You can see so much with just a careful look and the right technique. If you understand what you're seeing, you can pick up a lot before you ever order a single test. We'll start with the big picture, the anatomy and physiology, and then we'll work our way into the history, the basic bedside exam, and the diagnostic tools you'll see in practice. The eyeball sits in the orbit, which is the bony socket that protects it. Inside that orbit, the globe is cushioned by fat and supported by muscles and connective tissue. The optic nerve and the ophthalmic artery come in through a small opening at the back of the orbit called the optic foramen. 6 extraocular muscles, 4 rectus and 2 oblique, move the eye in all directions, and they're controlled by cranial nerves 3, A4, and V6. When those muscles work together, both eyes move in perfect coordination, and the brain blends the two images into one clear picture. The eyelids are thin folds of skin with muscle and glands inside. The upper lid normally covers the very top of the iris, and it's lifted by the oculomotor nerve. Along the lid margins are the meibomian glands, which help make the oily part of your tears, as well as the puncta, which drain the tears, and of course the eyelashes. Every time you blink, the lids spread tears across the cornea and conjunctiva. Those tears aren't just water, they have 3 layers. An oily layer that keeps them from evaporating, a watery layer that brings nutrients, and a mucus layer that helps them spread evenly. If you lose any one of those layers, the cornea can dry out and get damaged. Covering the white of the eye and the inside of the eyelids is the conjunctiva, a thin, clear membrane that meets the cornea at the limbus. The wall of the eye has 3 layers. On the outside is the fibrous layer made up of the sclera and the cornea. The middle layer is vascular, called the uveal tract, and it includes the iris, the ciliary body, and the choroid. The inner layer is neural, that's the retina and the optic nerve. Inside, the eye is divided into 2 segments. The anterior segment includes the anterior and posterior chambers and is filled with aqueous humor. The posterior segment holds the vitreous humor, a gel that helps the eye keep its shape. With age, the vitreous shrinks and can create floaters. The cornea itself is crystal clear, has 5 layers, and is packed with nerve endings. That's why even a small scratch feels so painful. The iris is the colored part of the eye with a hole in the middle, the pupil, that changes size to control how much light comes in. The lens sits just behind it, focusing light onto the retina. With age, or with conditions like diabetes, the lens can become cloudy, forming a cataract. The retina is a layer of neural tissue that contains rods and cones. The rods help you see in dim light, the cones let you see color and fine detail. The macula, in the center, is responsible for your sharpest vision, and the very center of the macula, the fovea, is the most precise point of all. The optic disc is where the optic nerve leaves the eye, and because there are no photoreceptors there, that's your blind spot. From the retina, visual signals travel down the optic nerve to the optic chiasm, where fibers from the nasal halves of each retina cross to the other side, while fibers from the temporal halves stay on the same side. From there, the information travels in the optic tracts to the brain's visual cortex in the occipital lobe. The right visual field from both eyes goes to the left side of the brain, and the left visual field goes to the right side. Once you've reviewed the anatomy, the next step in a real patient is the ocular history. This is where you ask about any vision changes, when they started, whether they've been getting worse or better, and whether they came on suddenly or gradually. Ask about past injuries, surgeries, or eye problems. And always ask about family history, because a lot of eye conditions run in families. The pattern of vision loss can help you localize where the problem is. For example, damage to the right optic nerve causes blindness in the right eye. A lesion at the optic chiasm causes bitemporal hemianopia, loss of the outer visual fields in both eyes. And a lesion in the right optic tract causes a left homonymous hemianopia, loss of the left visual field in both eyes. After history comes visual acuity. This is your baseline, and you should check both near and distance vision. For distance, we usually use a Snellen chart at 20 feet. For near, a Rosenbaum card at about 14 inches. If the patient can't read letters, use a tumbling E or picture chart. Record acuity for each eye separately, OD for right, OS for left, OU for both. If they can't see the largest letter on the chart, you move closer and see if they can count fingers. If not, check for hand motion detection, and if that's absent, see if they have light perception. If not, they have no light perception in that eye. Then do your external exam. Look for ptosis, where the lid droops, or ectropion, where the lid turns out, or entropion, where it turns in and the lashes can rub on the cornea. That's called trichiasis. Look at the pupils for size, shape, and reactivity to light. Watch their gaze and head position. A head tilt might mean a cranial nerve palsy. Check for nystagmus, those involuntary eye movements. And finally, test extraocular movements by having them follow your finger through the 6 cardinal directions of gaze. Once you've done your bedside exam, you can move into diagnostic evaluation. Direct ophthalmoscopy is the classic next step. In a dark room, you use a handheld scope, your right eye and hand for their right eye and vice versa. Focus on a blood vessel and follow it to the optic disc. Check the cup-to-disc ratio, the clarity of the disc margin, and look for retinal changes like hemorrhages, lipid deposits, cotton wool spots, microaneurysms, or drusen. Indirect ophthalmoscopy is done by ophthalmologists for a wider view of the retina, and the slit lamp exam lets you magnify and light up the anterior and posterior parts of the eye. You can check the cornea for scratches or edema, the anterior chamber for inflammation, and the lens for cataracts. Tonometry measures intraocular pressure, essential for glaucoma screening, but make sure the patient doesn't squeeze their lids, hold their breath, or bear down during the test, because that can artificially raise the pressure. Color vision testing is often done with Ishihara plates, those colored dot patterns that hide numbers or shapes. It's important not just for daily living, like driving, but also because changes in color perception can point to optic nerve disease. The Amsler grid is a simple test for macular function. If straight lines look wavy or areas look missing, it may be a sign of macular degeneration. Ultrasonography can be used if the retina isn't visible due to cataract or bleeding. B scans show tumors, detachments, or hemorrhage, while A scans measure eye length before cataract surgery. Optical coherence tomography, or OCT, uses light to give detailed images of the retina and macula without touching the eye. Fundus photography documents what you see in the retina, and laser scanning can give a 3D map of the optic nerve to track glaucoma or papilledema. Angiography uses either fluorescein or indocyanine green dye to highlight the retinal or choroidal circulation. We check kidney function first, make sure the patient's hydrated, and let them know they may feel a brief warmth or metallic taste when the dye goes in. Their skin or urine may change color for a day, and that's normal. Finally, perimetry testing maps out the patient's visual fields. This helps find blind spots in central vision, like in macular degeneration, or peripheral loss, like in glaucoma. So to sum it up, the eye exam starts with what you can see, but it builds on that with history, bedside testing, and specialized diagnostics. As a nurse, you need to understand the purpose of each step, prepare the patient, and appreciate how changes over time can signal disease progression or response to treatment. In our next session, we'll take this foundation and apply it to common eye diseases, glaucoma, cataracts, macular degeneration, so you can connect what you find in the exam to what's actually happening inside the eye.